All right, before we understand the concepts of EMRs and the different modules within that, it's a good idea to understand how did we get here, what happened in the last 10 years, how did the rapid acceleration and adoption of EMRs take place, what were some of the background and the key drivers. Understanding this background would help us appreciate why we need to understand more about EMRs, specifically from an academic standpoint, and also when you get into the job market, how that is going to help you and how you should see that market would set that context clear for you. So I thought I'll just make this episode, spend a few minutes of airtime and giving us some background. So let's get started. So first things first, what does EMRs and EHR stand for? EMR is nothing but it stands for electronic medical record, and EHR is electronic health record. And the basic difference, without getting into the specifics, EMR you can consider as very episodic. For example, if you go and see a doctor as a patient, whatever happens in that episode, it could be one episode, it could be kind of for the lifetime of your visit to the doctor, or slightly broader, but it's more episode or group of episodic, or it's confined to a care setting. For example, if you go to one hospital which is on one network, or a doctor who is on one network, and if you go to the other network, it will be two different systems, so your record is not going to be shared, or you will not have a kind of a holistic vision of your care. And EMR, more than likely, it is confined only to the clinical data. That's one thing. So medical related, that's a part here. It's only clinical related. Whereas EHR is much more of a broader term. It's holistic in nature. It covers your health more than the medical episode in specific over a period of time, and it could be over a period of lifetime, and it could be across care settings if you're visiting doctors across networks. So it's like your curriculum vitae or a resume after you graduate, or since you have taken the first job until now. So it's your whole history of kind of a thing, and it could include not only clinical data but non-clinical data also, which could be your pharmacy data, it could be your insurance data, and all those things. It could be much more than that. So I assume for the sake of this discussion, we'll focus on EMR, and we'll use EMR predominantly. But for the rest of your life, as long as you're working in health IT, EMR and EHR, these words are going to be used interchangeably, and you don't have to really worry about that. The difference is very subtle. As long as you understand difference in terms of daily work and daily usage, you can use this interchangeably, and we will do likewise in this episode also. Okay, the first and foremost thing is, let's get some numbers, facts and figures. There's no fun of understanding healthcare IT or EMRs without the numbers. And these numbers are going to be interesting and also alarming at the same time. And like I say, if you get yourself into the habit of understanding the gravity and the nuances behind the numbers in general, not only in this topic, in any topic, then you're already in the business of understanding the business. And that's going to be with or without an MBA. You just need to start getting into the habit of consuming the numbers, understanding it, putting it in a perspective, and just understanding the magnitude of what these numbers mean and what is a reflection of that. Specifically, if you're going to do MBA or you're doing MBA and in health IT, understanding these numbers is very important, because this is what is going to drive your opportunities in terms of where the market is going, how large is the market, and how should you think about that, and also helps you from a job prep standpoint. Anyway, that's a side note. So let's look at some of the numbers real quick and get into the state of current affairs, why EMRs and why it is important. Okay, so let's talk about the healthcare spend in the US in general. So if we talk about the US in general, the overall US economy is roughly $21 trillion. And if you don't know how big that is, don't worry about that. It's the largest economy in the world as of today, $21 trillion. And US healthcare expenditure as a whole, all put together, roughly if you see, even if you take the current state of 2021, it's roughly 18% of this $21 trillion. And even if you take 2020, it's still close to 18%. And in terms of absolute numbers, it comes to $4.1 trillion. Okay, that's a big number, very big number. And let's see how big number that is. Okay, so if you see India's GDP as a whole, we're talking about just the US healthcare spend. We're not talking about anything else. We're not talking about US GDP. US GDP is $21 trillion. If you talk about just the US healthcare spend, we're talking about $4.1 trillion. Okay, and that was in 2020. Okay. If you just take the India's GDP, India's overall national income, if India was an individual, how much does it earn every year? And even if you take the 2020 or 2021 numbers over here, and if you just take it, it's going to come somewhere in this range, okay? $3 trillion to $3.2 trillion. So assume that India today is a $3 trillion economy. And let's say as per the projections, we are growing at 10 to 12%. So let's assume that we might be, say, $3.25 trillion by the end of next year, ending December 2021 or 2022. Okay, let's put that. Even if you take the higher number, $3.25 trillion, that's the economy of India as a whole, all of it, right? This number beats us just on the healthcare side. So what does it mean? The US healthcare spend easily eats up in terms of the magnitude, where we have $4 trillion, and this is much, much greater than the overall GDP of India, which is $3.25 trillion. So that's the amount of spending the US healthcare does. So that's where the problem lies. And let's see what's happening and how are the guys trying to solve the problem. Okay, that's just the magnitude. And then another interesting fact is, if you see the US growth rate as an economy, right? If you see from 1970s or wherever it is, let's take this one just for the fun part. The overall economy of US, okay, the $21 trillion that I spoke about, 21 trillion, the overall economy, the size of this pie is growing roughly at 3.4%. This was an average rate before Corona or even today. It's, the COVID impact is not figured out. The COVID impact must slightly change the numbers, but let's assume that the overall growth rate, at least as per the trend, this was more of a trend, was 3.4%. That's the size of the economy. And if you see the adjustment, the growth of the spend on healthcare, that's more than the economy. So healthcare is interestingly more expensive than the overall national income of the US. So interestingly, healthcare and education, getting a college degree, these are the only two things that has grown more than the inflation in the US. Inflation in the US has been always less than 2% of the GDP every year. So this has grown more than that. That's an interesting part. Now let's see what is the big deal. Maybe they're spending more, so they might be getting some better output. Let's figure that out. And in terms of comparison, if you see, US is the highest in the world in terms of spending. This is a graph of some advanced economies. This might be old graph till 2015, but the trend is still, you see, other economies are kind of centered around here. US is still growing, and it's much deviating, and the spend is huge here. Okay, so now let's put the perspective of cost and quality. Where does it stand in the quality side? Okay, so if you just compare the apples to apples peer economies who are advanced or Western countries, and if they have, this is a survey which has taken the 11 nations, which we can assume that they're rich nations in terms of overall GDP per capita and advancement. So put together, in the world, US spends the most in healthcare, but even if you compare with their peers of advanced economies, US is rated the lowest in terms of the healthcare quality indicator. Over here also you can say it's low. And in another dimension, what are the dimensions that you compare the healthcare quality? There is an index here which talks about quality of care, access of care, efficiency, and all the different parameters. And in that parameters also, if you see the comparison between the 7 countries, which is 1 to 7, which is a subset of these countries. Here we are comparing 11 countries. So in that also, US is kind of ranked the last on all the parameters. So what are we learning here? What is the moral of the story? The moral of the story is higher cost does not yield better quality. That's what we are talking about. So, and that's the problem statement now. So we are spending significantly on the cost, the US, and the quality is significantly lower. So what do we do about that? And that's the $1 million question. And that's the mission that they are embarked for the last 10 years of how do you manage this quality and quality conundrum? How do you reduce the cost and you better the quality? So cost has to go down and quality has to go up. The arrows are reversed here. If you see the direction of arrows has to be reversed. Okay. And the question is, how do we do this? How do we measure this? And how do we manage this? That's the $1 million question. And to do that, to measure and manage, one of the most important things that we need is data. That's the biggest barrier to get entry. If you don't have the data with you in any format, it's hard to measure. And if it's hard to measure, and you cannot manage it, or vice versa. So the biggest problem that they saw is, we know the cost, that they have the data on the cost. They have the data on the cost, saying that, okay, it's a $4 trillion, but where it is going, how are we spending, why it is going, there is no way to measure that collectively. And that was kind of the first driver in how to think about that. And the natural solution to that was, let's collect the data first, let's get it together, let's compile, gather, store it in some format, and let everyone store it, and then we'll figure out how to fix it, how to fix the problem. Okay, that was the natural solution. And the solution to the problem statement was like EMR. EMR was a natural winner, because we need a place to store the EMR, to store the data, sorry. When the patient goes to the doctor, if there's a patient and he goes to the doctor, the entire data is over here among many other data. But we're talking about the clinical data, because EMR stores clinical data predominantly. So where do we store this? So we need to store it in some electronic format. So EMR was kind of the concept. It's not that the concept was new or it was the first time it was introduced, but the prominence, the relevance, the acceleration of EMR kind of shooted up during this phase when this problem was trying to solve. So they said that the government, the US federal government, saying that let's use EMRs to collect the data first, and then we'll figure out. So in the overall journey of the cost and the quality, EMR became the first stepping stone or entry point to capture the data during a patient visit. And that is what led to the acceleration of EMR, and followed by the adoption of EMR. And just as a quick note, EMR was a natural extension to an existing HIS. It's not, like I said, it's not that the first time we were using some electronic format. So predominantly all the systems, at least in the US, they were having some sort of electronic way to capture, and they were predominantly HIS, or hospital information system, which is what predominantly we use in India today in a loose format. Not all hospitals use, but wherever you go to a clinical setting in India, if they're doing something with computers, they are using an HIS predominantly and not EMR. So EMR was a natural extension to an HIS, because we wanted to store, at least to start with, the clinical data and then do the rest. And HIS was, although it was an electronic way of storing data, but it was more used as an internal administrative tool from the hospital side to schedule, make appointments, and do the billing information, right? It was not used for a lot of research and a lot of compilation and a lot of aggregation to understand what's going on, and tying back the cost to the quality of that, tying back cost to the patient data and what's going on, why that is costing you that much. So EMR was kind of the natural solution to that. Okay, that's one thing. Okay, so now what happens? Now Uncle Sam comes in play. So this is like we're talking about 2004, 2009. The discussion starts happening in 2004. And finally in 2009, when Obama comes in the government, he kind of mandates, like, let's computerize all the health records within 5 years. And there's a lot of incentives given to the government to start with that. And the first entry point to do that is everyone has to adopt any EMR of their choice and store the data in the EMR. We want to make sure they're storing the data. And that's how the whole acceleration about EMRs, or electronic health records, started getting into action, roughly in the early 2009, from that point onwards until today. Okay, and that was called as the high tech act, high technology. Okay, it was a technology act, like use of technology to gather data. And then different concepts came in picture. I'm not going to go deep into that, but that was the overall background. And the thing that said is, let's first, meaningful use. What was meaningful use? The first reform they had using EMR, what they said is, let's divide that into 3 stages, the High Tech Act. So what you do is, first you adopt the EMR. Let's make sure everyone is adopting the EMR. This is a timeline from 2009 to 2015, and we can extend it to 2020 also. Okay, so by 2019, I think we can stop here. So let's first adopt the EMR. Let's use some electronic way to capture the data, okay, and share the data. And then after so each phase was roughly three years in play, each stage. And then what they did is, okay, now you have captured the data. Now let's see whether you can use it for making decisions, okay, or you can use it to better care. And then in the last stage, they say, okay, now you're bettering the care, Now let's try to implement the outcomes, which is not only cost, but we can talk about quality, or vice versa. It was not only quality, but cost and patient experience and everything else. Okay, that's a side note. We don't have to discuss much upon that, but it was implemented in the phased manner. But that's how it was done. This is more like, if I have to give you an example, assume that, okay, you have an exam, okay, and you have to score good. Okay, so now my objective is all students should score good. The score has to go up. Okay, that's my objective, and exam is a way of measuring that. But for studying for the exam, you need a book. Okay, so let's say it's stage 1, I buy you a book, I give you incentives to buy you a book. But does that mean I want to make sure every student has the money to buy the book, or they should buy the book? Okay, if they have the money or whatever reason. Okay, so that's my first stage, because if you don't have the book, you cannot study. That's your stage 1. Okay, but does buying the book mean that you're studying? No. So once everyone has bought a book, now I'm going to go to stage 2. I'm going to make sure that everyone studies the book. Okay, everyone studies the book. That's the stage 2 part of that. So people are going to use it meaningfully. They're going to use a system. But just because you study the book and you prepare, does it mean that you're going to get good score, or you're going to score is going to up? No. That means I need to enforce something in stage 3, where I ask you the proof that you bought the book, you studied the book, show me the score, and show me that there is an improvement in the score. And I'm going to incentivize or penalize for you on that one. So you can compare these stages in that format: incentive to adopt or buy, incentive to use, and incentive to show outcomes. That's kind of the overall meaningful use, but that was primarily done using the EMR data. So that was the backdrop of how did the overall EMR game begin, or was fast tracked starting from 2009 once Obama came in until today. Okay. And now let's try to understand what is the magnitude of this spend. Like, okay, EMRs are being adopted, there's a lot of push towards that. Let's try to understand, put some numbers around how much is the spend on just the EMRs. All right, let's use these visuals to talk about that. So if you see here, the EMR market, and it's just the hospitals, okay? But US healthcare is much more than the hospitals. There are clinics, there are urgent cares, and so on and so forth. But even if you assume that this is the overall market, which is not true, even that just number for the 2020 estimated, E is for estimated and P is for projected for 2025. But even if you take the 2 years back during the pandemic year, the EMR projections just for the hospitals was a staggering $14 billion in the US market. And if you just compare that, just to get an order of magnitude or how big that is in terms of the overall healthcare spend for the same year in India, if you see the overall healthcare spend, not only the technology, all of the government, all spent to put together, India's public health expenditure in 2020 was around 1.29%. So assume that it was roughly 1.3% of the GDP. Okay, so if you take that and put that in a perspective over here, just the EMRs, just the technology spent only on EMRs specifically for hospitals was around $14 billion in the US. And India's overall public expenditure, even if you take 1.3% of a $3 trillion base GDP, it comes to around $39 billion in the US market. So although this number looks big, but it's for the overall country's all-inclusive spend, and this was just a small portion of tech spend on the EMR. So that itself shows roughly this is like, say more than 50% of, let's say 50% you can count, 55% of the spend, right, of the India spend. So that's kind of magnitude of how big this market is, to just get a sense of where this is going. Okay, what next? Let's see what is the next topic we have in this. Okay, on a side note, let's also understand how that is relevant to the changing Indian landscape of healthcare and what it means. So all of you guys would have heard by now the Prime Minister's new announcement on the reforms that started 2 years back on Ayushman Bharat, and now that was more on the insurance side, but now that is kind of transformed into a complete program by itself called as Ayushman Bharat Digital Mission, or it's called as ABDM. And what it is nothing but integrating all of the health records together. So in a way, they are trying to create LHR, which means longitudinal health records, which is what kind of EHRs are all about, longitudinal health records. And what it means is each patient, it's a voluntary program, but if you register, each patient or each enrollee will get a unique health ID like a Aadhaar ID but different from Aadhaar ID, and this will be a health card, and that can be used across different point of care or wherever you are presenting it. Doesn't matter which doctor you're visiting, which state you're visiting. Using this health card or health ID, all of your medical history can be tracked, at least going forward, so it will be in a cumulative fashion that you can track. And that's also is happening. So although the program is Ayushman Bharat Digital Mission, but if you see under the hood, the underlying technology play is going to be the core EHR or EMR, where India is not using much of that. Like I said, India is more using HIS in some loose way, but this mission will enforce going forward. They're using the combination of a health ID and a technology to store all the record. If you want to access your data from anywhere, then there has to be a digital system, an electronic way to capture the data, store the data, and make it accessible. And that electronic system is nothing but going to be an EHR EMR play. So you'll see that there is proliferation of this EMRs and EHR slowly in the Indian ecosystem also under this program, and you will see the prominence of this also raising along with all of the other healthcare ecosystem like insurance and point of care and other players. So that's just a quick side note on how the whole concept of EMRs is also shaping in the Indian landscape. Obviously, we'll not be spending as much as money as US in the EMR market, but we'll have our own way of digitizing, just how we did Aadhaar and other things. So that's kind of a good summary on the backdrop of where we are in the EMR, why we are here today, and kind of the drivers for that. And with that segue, we can get started into our next discussion, where I'll be talking about the EMRs, different types of EMRs, and the modules in specific. And that way you can relate what is being taught in that episode to the business context of why we are here. Hopefully this session was useful. I'll see you in the next subject.